Shall we start, Abhishek?
Yes, it's about 8:29 within a
Okay,
minute or so.
sure. Okay. So we are live streaming this as well. So anybody wants to join through the live stream that they can. So this on the platform, it will be more interactive, so they can ask questions. Live stream, they may not be able to ask the questions, but yeah.
So live streaming will be on technochronology.com.
No, it's on Endocrinology India website, the
Okay.
YouTube channel. So it's there. There are people who may not be able to join on time on the Zoom link, so they can go there. But
Okay.
we'd encourage them to be on the platform. So that's always
Okay.
better.
Okay. Fine, sir. Can we start now, sir?
Yeah,
8:30?
absolutely.
Sure. Let's start. Good evening, all. It is indeed a great pleasure for us at Zuventus to welcome you all to this insulin resistance mastery. Advanced Management Techniques, a comprehensive four-part series exploring insulin resistance from diagnosis to intervention. Through this series, we shall deep dive into the pathophysiology and mechanism of insulin resistance while mastering practical strategies to manage patients with metabolic syndrome, prediabetes, and diabetes. Also, gain evidence-based tools to effectively reverse metabolic dysfunction and improve patient outcomes. My name is Abhishek Kanyalkar, and as marketing manager on behalf of Zuventus, I consider it as my proud privilege to introduce our faculty, Dr. Om Lakhani, consultant endocrinologist from Ahmedabad. Dr. Lakhani is founder of Mellitus Healthcare and Technocrinology.com. Is a winner of President NB Gold Medal in Endocrinology, winner of 2 gold medals in MD, and winner of 5 gold medals in MBBS. He is considered as a leading figure for the use of AI in healthcare. With about 30 publications and 20 book chapters, Sir has keen interest in embracing technology and endocrinology. May I now request Dr. Lakhani to take the session forward? So it's over to you.
Yeah. Thank you, Abhishek, for the kind introduction. And welcome everyone. There are close to 74 participants live and several on the Endocrinology India channel as well. So welcome everyone. I think we have been planning this for a long time, as Abhishek knows. This is something which has been in our minds for a long time, and it's a great privilege to have all of you here. Now, I'm going to first introduce you to what we are going to do in this course, and then later on we'll start the actual lecture. So just allow me to share my screen. So is my screen visible, Abhishek?
Yes, sir.
Yeah, okay, great. So we are going to do this, in the usual technochronology way. So some of you would have attended some of our earlier webinars as well. So, but those who are new to this, let me tell you how it goes. So we are going to have a series of 4 webinars, each of them covering different aspects of insulin resistance. It's going to be a practical learning experience. So whatever we're going to do is going to be integrated with what you're going to use in clinical practice. Now, these are the 4 chapters that we're going to cover. So the first one is today, that is insulin resistance, the physiology and pathophysiology. The second chapter will be the clinical and biochemical diagnosis and quantification of insulin resistance. So that is where we'll be discussing the clinical aspects of insulin resistance. We'll also be discussing all the, the HOMA IRs and the quickies and the hyperglycemic euglycemia clamp and all these, systems of how you can measure insulin resistance. And then we'll go on to discuss the management of insulin resistance, where we'll be discussing about the role of PPR gamma, the lobeglitazone, pioglitazone, the role of metformin, the role of some of the newer drugs in this pathway. And the final one, which is going to be very exciting, we are going to discuss about the consequences of insulin resistance, where we are going to discuss about how insulin resistance impacts the overall outcome of a patient, how it impacts for example, how it involves atherosclerosis. So we'll involve a cardiologist, we'll probably involve a nephrologist as well. We'll see how, we'll see a panel of experts and we'll discuss how it's going to work out in terms of the overall pathophysiological picture. Now, at the end of the 4 webinars, which are weekly, you will be eligible for a certification. So we'll have a quick exam. Don't worry, we'll pass everyone. The idea is to, sort of just to check your knowledge of what you learn, and then you'll get a certification, a certificate of participation from us, which will be available to you. Again, we encourage that you attend all of these lectures live so that you can ask questions, you can interact with us. There are a lot of polls also which which will be part of this. So you can put your questions in the chat box. We will be allowing some of you to unmute yourself and also ask questions in the end. So right now, I'll just advise you that you put your questions in the chat box. Additionally, there is a series of material which will be available to you. So for that, we put the link in the description in the chat box right now. That's the platform called technocrinology.com. And in this platform, you will be able to get all the lectures which you're going to do. We are going to record that and put it up there. Additionally, you'll get additional reading material. We also have this pre-read notes and materials. It's a detailed PDF which you can download. It's a detailed series of notes which you can download and you can read. Again, it's the most extensive notes you have on this topic. So you won't find more detailed notes on this. Okay. Additionally, there are some additional notes which are part of this lecture notes. These are very simple to read, easy to read. In fact, you'll enjoy reading it. You'll understand a lot of fundamental aspects, as well as it's very simple and easy to read kind of material, right? So you'll get all this material here. So you can go through the material. There'll be some reflection points where you can just reflect on what you learn. And additionally, you will be able to, there are certain multiple choice questions also, which will be there on the system, which you can answer, and you will be able to again check your knowledge on this system as well, right? So this is how it will look like on the technocrinology.com platform. Okay. Now, so this is the introduction, but without much ado, let's begin today's lecture series. And again, before I begin, a big thank you to Zuventus Healthcare. I think that's, am I getting it right, Abhishek? I get it, a little bit wrong all the time, right? So it's Zuventus Healthcare, which, are pioneers in innovations in healthcare. So I think that is the great part. You'd have recently heard about the once a week gliptin, which has been launched by them, which is, I think, unique. You don't have a product like that in the market. Also, they are pioneers in lobeglitazone, which we'll be discussing in great length at a later date. So I thank them for the sponsorship of this event. It's because of them that this course has been made free of charge. So unlike some of the other courses which are paid, this is one which is completely free. So you have the best material available to you at free of cost, right? Additionally, let me say there is complete editorial freedom on this. So there is no participation from a pharma angle. It's a complete educational grant. So with a complete editorial freedom. So what you're going to get is an unbiased view of the entire series. Okay, so let's begin. And today we're going to discuss 3 things, all of the 3 which are essential to our understanding of insulin resistance. So these are very basic topics we're going to cover today. So we'll take it very slowly. We'll take it step by step. We'll allow you to learn, digest, reflect back, and then come back to us. So what we're going to discuss today is what exactly is insulin resistance. What do I mean when I say the patient has insulin resistance? We'll also discuss a little bit about biochemistry. I know it's not nobody's favorite topic, but in fact, you'll enjoy the biochemistry today that we're going to learn today. We'll discuss the insulin resistance, the insulin receptor, and the insulin resistance at the cellular level. And finally, we'll discuss some other pathophysiology and physiological aspects of insulin resistance, which will help you understand the other topics, and you'll also understand what exactly we mean when we say insulin resistance. I'm going to show you some very interesting videos also, and some very interesting research work which has been done on this. Okay, so let's begin the first topic, and that is the physiology and pathophysiology of insulin resistance. And we'll start with what exactly do we mean by insulin resistance. Now, insulin resistance means 3 different things to 3 different people. Okay. Now, to a cellular biologist or to a biochemist, it means a pathophysiological process that happens at the level of the cellular level, right? So that's basically insulin. That is actually what insulin resistance is. So insulin resistance is actually the disease that happens at a cellular level. However, to a clinician, to a generalist, insulin resistance is what they see in clinical practice. So that is the acanthosis nigricans that we see, or the central adiposity that you see, or the lab reports showing high triglyceride or pre-diabetes or metabolic syndrome. That is what you see. That is what to a clinician is, and to a patient and somebody who is on insulin. Well, insulin resistance has a different definition there as well. So again, if you see from the insulin dosage point of view, and that's another definition of insulin resistance. Typically, it is said that if you're using a typically insulin dose of more than 200 international units a day, which is very high, but that is what is the definition, right? In total. So if your total insulin dose is more than that, that is what is insulin resistance, right? Again, this is a very diffuse definition, and again, you would probably, rather consider that as a, put it a little bit on the side. That is what patients feel what insulin resistance is. But for us as clinicians, I think the one in the middle is the one which is most important, and that is what we'll be discussing in the second chapter in the next week. But today we'll respect the biochemistry and we'll respect the cellular biology, and what we're going to tell you is what we mean by insulin resistance at a cellular level, and that is what we're going to discuss. Okay, now, so we all know what insulin is. We all know that insulin is a hormone, and it's a hormone which is released by the beta cell of the pancreas. Now, this hormone is then acting at a receptor, and then it has certain downstream action which happens at the post-receptor level. Its primary role of insulin as a hormone is to allow glucose to enter the cell. Now, just again, a little bit of a kind request that if you have a question, you can raise your hand, but what I suggest is put the question in the chat box so that we can answer them during the course of the lecture. And in the end, we'll allow all the people who raise their hands to come on live and ask their questions. Okay, moving on. So basically what insulin, the main purpose of what and how we understand insulin is that what insulin does is it allows the glucose to enter the cell. So that is what ultimately insulin, the main role of insulin is. But it's not that simple, right? Insulin is actually an anabolic hormone. Now, why is this insulin resistance very important? Why it's important? Because in today's world, most of the diseases that we are dealing with, the metabolic disorders, have something to do with insulin resistance. Now, type 2 diabetes, we all understand. Let me come to that in a minute. The other diseases like PCOS, atherosclerosis, central adiposity, these are all MASLD. These are also linked with insulin resistance. So insulin resistance is not just type 2 diabetes. Insulin resistance also covers other disorders like PCOS. It also covers a disorder like an MASLD. So insulin resistance is involved in other diseases also. And that's why it's very important that the drugs that you use in insulin resistance are also used in these diseases. For example, something like a lobeglitazone or pioglitazone will also be used in a patient with MASLD with diabetes, because there is insulin resistance at play at that level. Back in the day, I remember I used to attend some of the lectures by the endocrinology department of PGI Chandigarh. And they had this theory, which is very interesting. And they've said this on stage many times. What they say is that in PCOS, why don't we use pioglitazone, right? In fact, it could be a great drug, right? So of course, there were no clinical trials done, but that is what they said. While we do use metformin, but maybe pioglitazone, of course, it leads to a little bit of weight gain, but there could be a potential role there. So ultimately, all these diseases are linked with insulin resistance. Now, let's focus back on type 2 diabetes. Now, the thing about type 2 diabetes is that, and you would have seen, we have another lecture on this topic called the unifying hypothesis for understanding diabetes. Now, I have a theory that diabetes is actually, though we are separating it into different, subtypes like type 1, type 2, gestational diabetes and so on, there is a way in which you can unify them. Essentially, diabetes is an imbalance between body's ability to produce insulin and the insulin resistance. Now, as long as the body's ability to produce insulin matches the insulin resistance, you are in a euglycemic state, right? So your blood sugars remain normal. But when one of the two becomes imbalanced, that leads to hyperglycemia. So when insulin resistance is more than the body's ability to produce insulin, then you are having hyperglycemia. Now, you'll say, how does it unify all these systems? Let me tell you. For example, let's say you have a patient in a euglycemic state where the insulin resistance and the insulin production are completely matched. So your blood sugars are normal. Now, initially, what happens in obese people or in people with pre-diabetes or people with metabolic syndrome, the insulin resistance keeps increasing. But what the body does, it matches the insulin production to match the insulin resistance. So insulin resistance keeps increasing, but the insulin production also keeps increasing. So there is still a balance which is reached. So even though the insulin levels are very high and there is insulin resistance, at the same time, what is happening that the body is compensating for that with increased insulin production, and the patient maintains normal blood sugar, maintains euglycemia. So that's the interesting part, right? So you have this thing increasing and the other thing matching. Now, interestingly, what happens when you have type 2 diabetes? At some point of time, the body's production of insulin cannot match the body's insulin resistance. And that is where the mismatch happens, right? And at this point of time, the hyperglycemia occurs. So even though type 2 diabetes is a disease where the pathophysiology is essentially insulin resistance, the rate limiting step, the point at which hyperglycemia occurs, is still determined by body's ability to produce insulin, right? So when the patient is diagnosed with type 2 diabetes, the patient is already having some sort of insulin deficiency, right? Even though that is not a complete insulin deficiency as you see in type 1, you have some sort of insulin deficiency, you have some sort of beta cell dysfunction which already sets in. So that is basically what type 2 diabetes is. Now here, I have another important argument which I always say. The problem with our disease management system right now is that we are treating these patients when they develop diabetes, and that point of time, the insulin resistance is already too high, and the body's ability to catch up to this insulin resistance is not that much. So the point at which you should be treating is actually even before the patient develops diabetes. You should be treating these patients when they are having insulin resistance and not when they develop diabetes, because that is already some lot of time which is already gone. Unfortunately, our ability to recognize patients having insulin resistance is still very limited, but we are going to solve that problem with this lecture series. Secondly, the problem is that at the level of the patient is not motivated to be treated until they develop diabetes. So that's the problem. Secondly, you will say, how does this entire thing match with type 1 diabetes? Well, in type 1 diabetes, it's a little bit different. The insulin resistance generally remains the same. In fact, in certain cases, there might be slight increases in insulin resistance, but there's a sudden drop in the beta cell function. So again, there is a mismatch. So here, it's like this. Insulin resistance and insulin and beta cell dysfunction both increase. This is what leads to pre-diabetes. Okay, let's take it this way. Insulin resistance is more than the body's ability to produce insulin. There's a mismatch. This is type 2 diabetes. But both of them are at this level and the insulin production goes down. That is when you have type 1 diabetes. Same thing happens in a pancreatic diabetes where you have reduced amount of, again, beta cell function. So essentially, in all these conditions, the play of insulin resistance and beta cell function remains the same. Only thing is, there is a mismatch in terms of what predominates in terms of the disease action. So I hope this is clear. Now, essentially, let me give you an analogy to this in terms of lock and key. Now, what is insulin resistance? Typically, insulin, and just like many other hormones, there is a lot of specificity to where it binds. So insulin is supposed to bind to a receptor, right? Now, it's like a lock and key system. So it is something like this, that you go to a hotel where there is a bellboy who guides you to the hotel room, right? Now the bellboy has the key to open the door. Okay. So in a normal situation, what will happen is that, so the bellboy is basically insulin, right? With the key, bellboy with the key is the insulin, right? You are the guest, you are the glucose, okay? And the door is the cell membrane, okay? Or we can say the insulin receptor, okay? Lock is the insulin receptor, the door is the cell membrane. Let's put it that way, okay? Now, essentially what you're doing is, when you're going to the hotel room, right? You are the guest, you want to get into the hotel room, right? So in a normal situation, the bellboy will take you, so he's the insulin, he'll open the door for you, right? Open the lock for you with the key, right? So he opens the door for you and you enter, right? So that is how the smooth system runs. Problem happens is that you have come up to the door. The insulin has also, the bellboy has also come with you. Okay, he has the key, but the lock is jammed. Okay, so he's trying to open the lock, it is not opening. Okay, so you're not able to get in, right? So you stay out. That is what is happening in insulin resistance. What happens in insulin deficiency? The bellboy is only not there. He's only, okay, there is no key, right? So there's nobody to take you to the door and open the lock. So that is the analogy which you have in terms of understanding insulin resistance. So basically, the guest is the glucose, the key is the insulin, the lock is the insulin receptor, and the door is the cell membrane, right? So that's how the entire system basically functions. Okay. Now, what happens when the door is jammed, when the lock is jammed? Okay. Like I said, the first body's action is to produce more insulin. So what the body does is, body feels that the glucose is not entering the cell. So to compensate for this, body produces more insulin. So there's more and more and more insulin which is being produced. More insulin which is being produced, at some point of time, the body cannot compensate for the increased insulin production, and that is where it starts deteriorating, and there is a reduction of the insulin production, and that is where that is the point of time you develop hyperglycemia, or what we now very well known as type 2 diabetes. So this is the entire system, how it goes. Now, eventually, over a period of time, what are the consequences of that? One is, of course, beta cell become exhaust. So it's like a horse which has been made to work more, right? And at very little reward. There are certain unintended consequences of the insulin. So the excess insulin you're producing has some unintended consequences. We'll see in the next lesson. And obviously, at the end of the day, you have glucose dysregulation, right? So the glucose which is supposed to enter the cell, it doesn't enter the cell, it stays in the bloodstream, right? The guest is supposed to go into the hotel room, he does not, he stays in the lobby and creates chaos, right? Shouts on the manager, shouts on the other guests, shouts on his wife, right? Naturally, right? So that is what ultimately happens, right? So that is what happens in terms of the glucose dysregulation. Right now, it reminds me of this very famous poem, right? The Rhyme of the Ancient Mariner. So the entire system is something like this: water, water everywhere. All the boats did shrink. Water, water everywhere, but not a drop to drink, right? So this is what Samuel Taylor Coleridge wrote in his Rhyme of the Ancient Mariner. So the problem is that you have glucose everywhere, but the glucose is not entering the cell, right? Because the lock and key system and is jammed, right? And that's ultimately what happens in type 2 diabetes. Okay. Now, there's a calm before the storm, right? Let's take the the analogy further, right? The problem with insulin resistance is that as long as the insulin resistance persists, right? So, before you develop diabetes, this insulin resistance has been there for many, many years. And this problem is that the long-term cardiovascular, renal, other consequences are often at this stage. And that is the stage when even before the diabetes develops. So there's a hidden damage, there's a hidden cost to it. And the HbA1c does not even reflect that, right? So that's the problem. Your still patient is pre-diabetic, and the damage is being consequently being done, but there's no action which is being taken, right? So this is like this classic joke, that it's, like I said, the philosophy here is that we are treating when the patient develops diabetes and not when we should be treating before the patient develops diabetes. So it's like this joke, I remember this joke when I was, often I heard about this when I was a child. But the patient goes to a physician and says that, sir, I have cough and cold. And he says, okay. great. You seem to have a viral infection. It's a self-resolving thing. ठीक है, 2-3 दिन में ठीक हो जाएगा. It will be fine, right? So patient says, no, give me some treatment, right? I mean, what do you treat? What do you give for a viral infection, right? Essentially nothing, right? So he said, do one thing. You go, drench yourself in water and go out standing in the cold naked. So he said, patient says, it's such an absurd suggestion. How is it going to help me? He said, look, what will happen is you will develop a secondary bacterial infection, and then I'll give you antibiotics because I know how to treat a bacterial infection, right? But I know how to treat a viral infection, right? So that's the joke. I mean, it's a sick joke, quite literally. But the point is that is what we're doing with diabetes. So insulin resistance has been there for a long time, but that we are not treating. We're saying, jab tumko diabetes hoga, then we'll treat, right? And that is the problem, right? We are actually wasting adequate, good time when we should be treating this patient earlier, right? So that's the problem. Okay. Now, the end consequence of insulin resistance, of course, diabetes, but it has other consequences also. Cardiovascular disease. In fact, we'll be discussing this in the 4th lecture, where we'll have some experts from other specialties also come in and discuss. It has consequences in terms of obesity and metabolic syndrome. In fact, weight gain leads to insulin resistance, but insulin resistance also can lead to weight gain. So there's a vicious cycle there. MSLD, right? PCOS, acanthosis nigricans, what you see in the skin. Some patients appear like acromegaloid, right? So pseudoacromegaly. We'll discuss that in the lecture today. Some patients develop gynecomastia, obesity, hypogonadism, and so on, right? So all these things are also linked with insulin resistance. Okay. So the issue is we need to detect early, understand this, and then consider treating this at an early stage. Okay. So the first take-home message from the lecture is that you need to understand what exactly is insulin resistance and what are the hidden consequences of the same. Okay. Now, we're not ending here, but we will have a poll question. When we run the poll, we'll take some of the questions which some of you have posted in the Q&A section. So Hitesh has asked, what is the difference between endogenous and exogenous insulin? Exactly. So it's a good point, Hitesh. This is exactly what I said. What we understand as insulin resistance is what technically is what basically is at the receptor level, right? So that is what essentially is endogenous insulin resistance. But when the patient is taking insulin from outside, the insulin dose requirement, and again, there are different definitions. 1 unit per kg per day, more than 1 unit per kg per day is considered high. Some people say more than 200 international units per day. I think it often differs. So I think it's not an exact definition. This has changed, but that is what is exogenous insulin resistance, right? So that is what basically we mean. Okay, let me launch a poll question very quickly for this. So, and it's a clinically oriented question, so you can try answering this. So a 35-year-old woman presents with oligoamenorrhea, hirsutism, and difficulty conceiving, and a lab test shows mildly elevated testosterone, normal prolactin, LH-FSH ratio, which is deranged, with a fasting insulin level, which is high, which an ultrasound shows polycystic ovaries. So basically, she's having PCOS. Which of the following based on the underlying pathophysiology, which additional finding would you be least likely to expect in this? So would you find acanthosis nigricans least likely to expect, right? Would you find elevated HSCRP, elevated insulin-mediated suppression of hepatic glucose production, and increased triglyceride to LDL HDL ratio, right? It's a little difficult question. Think about it, right? There's no hurry. We'll discuss the answers in the end, right? So, okay. Let's, meanwhile, we had one more question. We'll quickly take the second one as well. Yeah. So, Ambika has asked, proper physical activity or exercise is one major by which insulin resistance can decrease insulin resistance. What is your take? Yeah, I completely agree, right? So we'll discuss about the management in the upcoming lectures. Okay. Done. Okay. So let's then move on while you are answering the question in the poll. Think about it. Okay. Just think about it. We'll keep the poll on while you think. Okay. And we'll discuss that in the end. Okay. Okay. Now let's move to the second lesson in today's chapter. And that is insulin resistance at the cellular level, right? So now we are trying to understand the actual biochemistry of the insulin receptor and the insulin resistance. Okay. Now, Okay, so this is what an insulin receptor looks like. Okay, now insulin receptor is from a family of a tyrosine kinase receptor. It's a very interesting receptor. Just this is a very important lecture, right? Just pay attention a little bit here, right? It's something which will help you a lot. So insulin receptor is a tyrosine kinase receptor. It's very unique. It's very interesting how it works. So it has two subunits. It has an alpha subunit and a beta subunit. And the beta subunit transcends across the cell membrane. You can see here, right? So this is a cell membrane, and you can see the beta subunit going through the cell membrane. Okay. And the insulin binds with the alpha subunit. So this is how the entire thing looks like, right? Now at the beta subunit, the part which is inside the cell, it has certain tyrosine kinase enzymes. Okay, so we'll see how it basically what it does and how it works. Okay, now so it's a tyrosine kinase receptor, right? And it comes from that family, and other hormones like, for example, insulin IGF-1, which you see in acromegaly, right? So that's the growth hormone family, right? That also are the same, right? Its action is just like any other receptor. It's a signal transduction, and unlike some of the other receptors, there is some enzymatic action which happens at the inside the cell, right? Now it's something like a switch which is turned on, right? So it's like, for example, it's like a circuit. Okay, so you press a bell. Okay, let's take that analogy further. It's like the door thing, right? So you press a bell from outside, right? So it's a press a bell from outside, and the circuit goes in, and something happens inside the cell, right? Inside the door, right? That is how ultimately is happening here. Okay, now what essentially happens, and I'm going to show you the videos and everything to understand, make it as simple as possible for you to understand. Okay. In fact, let's go to the video itself, right? So this is a very nice video which will help you understand the process. Okay. Right. Now, this is like I said, the insulin receptor. So this is the extracellular component where you have the alpha subunit and the beta subunit, which is inside, right? Which is part of it is outside and part of it is inside, right? So this is the beta subunit. Okay. Now, these have certain disulfide bonds over here, right? Okay. Now, okay, so insulin comes here, it binds with the alpha subunit. Okay, now some of you would have, attended lectures and given lectures on insulin, right? About how the insulin structure is different and other things, right? So again, it's very important to understand how actually insulin really works in the human body. Okay, now here, once the insulin binds, it activates this receptor, right? Now, like I said, there are tyrosine kinase receptor. Now, what's a tyrosine kinase receptor? Basically, they phosphorylate certain proteins, right? So, and this phosphorylation activates mostly, and in some cases inactivates certain proteins. But most cases, it activates certain proteins. So it's like this, that once the insulin binds, it activates a series of cascades of phosphorylation, which activates certain other proteins, which does certain job, right? Simple to understand. So basically, insulin binds with the alpha receptor, it activates the beta receptor and beta part of it, right? And beta component, and then it activates tyrosine kinases, which basically phosphorylates certain proteins, which ultimately activate them, right? So one of the protein is IRS1, which then starts a series of cascade of events which happen downstream. Okay, so it's a long series of events. So you have something called a P1 PI3 kinase, and then you have further on the PIP2, right? And all of these are going to be future, targets for treatment, right? In future. So again, which activates to PIP3, and then you have your PDK1. You'd have heard some of this. You've heard about AKT. Not anti-cox therapy. This is a different AKT, and then it goes on downstream. And ultimately, what it does is it goes through series of multiple steps, and ultimately the main aspect of here, right, which is basically to allow glucose to enter, happens by entire system happening and then ultimately activating a glucose receptor, which is called the GLUT4, right? So essentially GLUT4 is present in the muscles and the adipocytes. So this is the GLUT4, and this GLUT4 gets activated. It opens the doors and allows the glucose to come inside. Okay. So ultimately, it's like, again, let me reiterate the entire step. So insulin binds with the insulin receptor, the alpha subunit. It then activates the beta subunit, activates a series of tyrosine kinase and it phosphorylates a series of proteins. The pathway which is essentially there is the the PIP3, PIP2, AKT, and ultimately as a series of cascades of events which activates the GLUT4, which allows the glucose to enter the skeletal muscle, right? Same thing also happens in adipose cells. So here's similar pathway happening in the adipose cell also, right? So these are two major cells where you have the systems being activated. Okay, now right, so this is how ultimately the activation process of insulin receptor takes place. Now what is interesting is this part. Okay, there are two pathways, right? I think I had, yeah, okay. I'll show you a picture in the next presentation. So there are two pathways. This is very important, again, very interesting. So one is the PI3K pathway, which is the metabolic pathway, where you have the downstream activation. Ultimately, GLUT4 gets activated and allows insulin to enter. But there is another pathway which is also activated by the same system, and that is the MAP kinase pathway. Now, some of you again would have heard about MAP kinase. So it's very important to understand that insulin is an anabolic hormone. Okay, while the PI3K pathway allows glucose to enter, the MAP kinase pathway is a pathway that is an anabolic in nature and helps in certain growth proteins, right? Activation of certain growth pathways. Now you'll ask me why it's important. Of course, it's important for growth of the cell and maintenance of the cell. But why it's important clinically? Because it also has link with cancer, right? And MAP kinase pathway, this pathway is a very important pathway which is now being targeted by a lot of cancer therapies, right? So you'll say insulin leads to cancer. No, it's an anabolic hormone. It doesn't lead to cancer, but it activates the pathways which ultimately lead to, right? So in fact, one of the problems with using insulin early on, especially the long-acting basal insulin, if you remember glargine, when it first introduced in the market, one of the major concern was, does it have any oncogenic potential? Can it lead to cancer? And that is, of course, it was dispelled. It was never found that it leads to cancer. But one thing then, that question in your mind remains, that if the patient has insulin resistance, can it increase risk of cancer? Answer is yes. That is another problem, right? And then you'll say, why OM would it lead to cancer? Because remember, it's insulin resistance, so it should block both the pathway. And that is the interesting catch. The insulin resistance ultimately affects only the metabolic pathway and does not affect the growth pathway, right? The MAP kinase pathway. So the other pathway is still active and this pathway is blocked. So the good road is blocked, the bad road is active. So the insulin continues to travel on the bad road continues to be activated, right? That's the strange part of it, right? So that's the interesting aspect, right? So the PI3K pathway is IRS, PI3K, AKT, GLUT4 translocation. And ultimately, this allows insulin to enter. And I'll again show you by this picture what ultimately happens when the insulin enters, right? So again, you have the insulin receptor, and this is the insulin which happens, which is there, right? And this insulin enters the, it binds with the insulin receptor, activates a series of events, right? And apart from the allowing glucose to enter, so this is GLUT4 where it allows glucose to enter, it has certain other metabolic effects also. So it has, one of the things it does is increases glycogen production. It, leads to accumulation of lipids and prevents breakdown of the lipids. So it encourages storage of lipids. It prevents insulin lipids from breaking into free fatty acid, which is very important. It also has certain effect on modifying gene expression and increases protein synthesis. So ultimately, if you see, right, if you see the video again, so the point is insulin, when it activates, it allows glucose, allows glycogen production, increase protein synthesis, and increase lipid storage and prevents breakdown of the lipids, right? Now, there is one very interesting research, and I'd like to show you that, which is there. This is called Minardo. Okay, this is see if I can probably add the link in the uh, uh, you know, I think mine should be there. Yeah. Okay. So this is called Minardo. I'm sharing the link in the chat. Yeah, this is the link. You can check this out. It's a very interesting animated system where they've shown the entire signaling pathway for insulin. Okay, so how insulin, what happens to insulin, and ultimately the entire. So you can see insulin binding here. Not only they've shown the entire pathway of all the proteins involved in the insulin system, they've also shown the time at which it happens. Okay, so when the insulin enters, within 15 seconds you have priming of glycolysis which starts, and within 30 seconds you already have the GLUT4 which is being translocated very early. The GLUT4 translocation continues for all the time. And then you can see here, all these proteins are involved, right? And like I said, these are future targets for treatment, right? This is the mTOR pathway. This is the cancer pathway, like I said. And you know, you have mTOR inhibitors and the cancer pathways here. You can see here the GLUT4s are activated, which is allowing glucose to enter. By 5 minutes, the GLUT4 is already translocated. So here it has already started moving within 30 seconds. By a minute, it has reached the cell wall. And then it is now open the cell membrane. It is now open to the cell membrane, and by 5 minutes the glucose has already started entering the cell. Then you have between 5 to 10 minutes you have glycolysis, which is happening. It extrudes the lactate, remember, and then ultimately they have the lipid systems are being activated at 20 minutes. So this you can see the entire timeline, and it's an active system which ultimately happens. And this is again part of a this is actually from Cell, which is a Nature publication, right? Now, I told you that there's another pathway which is there, which is called the MAP kinase growth pathway. And this is a pathway, again, it relays a series of transmission. Ultimately, what this does is it regulates the cell growth and survival, right? And why this is important? Because this is ultimately leads to cancer and the other complications, okay? Right. Now, this is when the glucose and the system is insulin resistance in the system that is activated, but it has to shut down also, right? So you have the system is now activated, and you have the glucose which is being, enters the cell, but the system also has to then close down. It has to shut down. Okay. So how does the system shuts down, right? How do you shut down the computer? Okay. So here there are various systems in which it happens. So one is insulin, the receptor itself gets internalized. Then all the phosphorylation gets dephosphorylated. So all the switches which are on gets switched off. Insulin itself degrades, right? And then there is a feedback regulation which prevents overstimulation. So this is how the system takes place. Because if this does not happen, then ultimately all the glucose gets sucked into the cell and the patient develops hypoglycemia. Right? So that should not happen. So the shutdown mechanism also is equally important, and that is also equally functional and active. Okay. Now comes the question, what is insulin resistance? So the insulin resistance is not difficulty for insulin to bind with receptor. No, it is not because of less number of insulin receptors. No, it is not because of that. It is the problem which is at the downstream level in terms of the action. Okay. And that also only one pathway, and that is the PI3K pathway and not the MAP kinase pathway. So the pathway which is good, which allows glucose to enter, is the one which is affected, whereas the pathway which is involved in growth is the one which is not affected, right? So, and like I said, it's a downstream, it's a post receptor action, which is basically insulin resistance. So again, if you're asked in an exam or anywhere, please understand this point. The problem with insulin resistance is not insulin binding with the receptor. No, it is not with lack of receptors. No, at least not in the classical context that we understand. And it is basically the downstream effect of one pathway which is being affected, and that is what is ultimately insulin resistance. Now, the question is why it happens. Okay, so that is what we're going to explore right now. Essentially, there are many ways, but there are two things which are, and this part of the lecture is very critical, and this is the key point, right? If you understand this, you understand pathophysiology of insulin resistance, you also understand why, and you also understand why these certain drugs which are there, they work. essentially, the insulin resistance happens because of two types of toxicity. One is lipotoxicity and other is glucotoxicity. Glucotoxicity, is a transient phenomena and can be easily corrected. Lipotoxicity is a more hidden phenomena, takes more time to understand and takes more time to correct. Okay, so what is this and why is this? So let's understand lipotoxicity first. And again, it's a vicious cycle. So what happens is that when you have increased amount of fat being accumulated, where does this fat go? Where does lipid go? All these lipids starts getting accumulated in the adipocytes. Now we have limited number of adipocytes, and adipocytes are living cells. So they have living breathing cells. So they produce their own hormones, they produce signals, they have their own blood supply. Now, when you stuff the adipocytes with more fat, then ultimately its blood supply is not able to catch up, and there is a chronic inflammatory state that sets in. Now, this chronic inflammation, it activates certain pathways called the serine proteases, which actually dephosphorylate some of the enzymes. So that is essentially what happens. So when you have chronic inflammation being set in inside the adipose cells, which acts opposite to the phosphorylation. Remember, phosphorylation was activating certain proteins. Here it sends signals to deactivate certain proteins. And because of that, the insulin action, which is supposed to happen in that signal, the chain algorithm, where it ultimately should lead to increase allowing glucose to enter, that system gets blunted because of inactivation of certain proteins that occur midstream. Okay, so there is a signal disruption. Now, because of that, the insulin, though present, though binding with the insulin receptor in the adipocytes, is not able to act. Now, one of the action of insulin was to allow adipocytes to accumulate the, so it's actually some sort of a defense mechanism. It is supposed to allow adipocytes to accumulate and to stuff fat inside the adipocytes. But because insulin action is not there, the adipocytes are now, that brake is released, and these triglycerides, which is a storage form of fat, starts getting dissociated, right, into free fatty acid. Now, there is a enzyme called the hormone sensitive lipase, which is acting at this point. This hormone sensitive lipase is a lipase which breaks down the triglyceride into free fatty acid and glycerol, right? So this free fatty acid, right, breakdown ideally should not take place. Actually, insulin inhibits this enzyme, but because that insulin action is not there, this inhibition is lost, and this triglyceride starts breaking down into free fatty acid, and this free fatty acid starts getting moved in the circulation, right? It starts moving in the circulation. It starts moving in the circulation. What happens? It gets taken over by certain other organs of the body, like the liver or certain muscles, right? The organs which should not be taking free fatty acid. In order to remove the free fatty acid from the circulation, it starts taking up this free fatty acid, right? And this free fatty acid starts getting taken up by, let's say, liver. And that is what leads to accumulation of fat in the liver, which is known as MSLD, right? So then you start developing insulin resistance at the level of the fat. So what started as an insulin resistance at the level of the adipocytes now becomes the insulin resistance in different other organs, including liver, including muscle. So that is the ultimate process. And then this insulin resistance at their level ultimately cycles to produce more insulin resistance and more problems, right? So this is the vicious cycle that sets in, right? That you have the adipocytes being stuffed. It is not able to take that anymore. It starts, for its own defense, it starts inactivating some of the downstream, actions of insulin. Because of that, the insulin action in the metabolic pathway does not take place. So there is a break on the hormone sensitive lipase is lost, which starts breaking the triglyceride into free fatty acid. And this free fatty acid gets released into the circulation, which gets taken up by other organs, and they start developing insulin resistance of their own, right? So this is the pathway, right? So this is the lipotoxic pathway. So this is lipotoxicity, right? And ultimately, on a chronic long-term basis, it leads to endoplasmic reticulum stress, which also perpetuates the inflammation, right? So this is the entire system, how it ultimately leads to insulin resistance. Similarly, there is another mechanism which can be easily corrected, is glucotoxicity, but we don't correct it. That's the problem, right? Glucotoxicity is again a similar pathway, but it is because of glucose. So again, this is a vicious cycle. So, and here, the problem here really happens to the pancreas, right? So the vicious cycle here is at the level of pancreas, right? So the lipotoxic cycle, and you have heard about the twin cycles of Roy Taylor and other things. Of course, he talked about another twin cycle, but there's another lipotoxicity glucotoxicity twin cycle which is there. So the lipotoxicity cycle I talked to you about, but there's a glucotoxicity cycle which is happening, right? So this glucotoxicity cycle, what is happening essentially is that you have increased glucose, and this increased glucose ultimately leads to insulin resistance, and this insulin resistance again, in order to compensate, the beta cell produces more insulin, but this more glucose ultimately leads to oxidative damage, and then that inhibits the ability of the beta cell to produce more insulin. So that ultimately leads to more glucose, right? And that leads to more glucotoxicity. So essentially, this glucotoxicity also leads to insulin resistance, but it also leads to oxidative damage and leads to beta cell dysfunction. So on one hand, you have the lipotoxicity cycle, which is perpetuating the insulin resistance. You have glucotoxicity cycle, which is perpetuating both insulin resistance as well as beta cell dysfunction. And ultimately, both these cycles combined lead to the type 2 diabetes, right? And some of the drugs which break down glucotoxicity very fast, is one of them is insulin, right? Insulin itself breaks down glucotoxicity very fast. So a lot of people argue saying that when you have insulin resistance, why are you giving insulin? Answer is, you're giving insulin not to basically compensate to deal with the glucotoxicity. You are giving it to with the lipotoxicity, you are giving it to deal with the glucotoxicity, which is equally a problematic system in the pathway, right? So when you're dealing with lipotoxicity, the drugs which deal with lipotoxicity are something like a lobiclitazone or paglitazone, or even SGLT2 and GLP-1. But when you're dealing with glucotoxicity, the drugs which act there are your sulfonylureas, are your insulin. These are the drugs which reduce glucotoxicity. So both have their role in diabetes management. And again, like I said, it's a very different way of understanding this. Okay, right. Now, moving on. So this is end of part 2, and let's see if you have any questions. Again, if you have questions, please post them in the chat. And I think we were dealing with interesting. What was it? Yeah, so poll. Okay, so we had asked you a poll. That you have this lady with PCOS, and which of the following would be least expect to find in the patients? Acanthosis nigricans you will expect to find. Elevated HRCRP, okay. This is, so 30% have answered this. Okay, let's end the poll here. Enhance insulin-mediated suppression of glucose production. Enhance insulin-mediated suppression. No, it will not be enhanced, right? In fact, this is essentially what is insulin resistance. So answer is actually this: increased triglyceride HDL ratio, which is again part of insulin resistance cascade, right? So, well, 46, which is great, a good number, did get the correct answer, right? So it was a trick question, you can say, but anyways, okay. So yeah, let's then take the second poll question. Let me launch the second poll question, and then we'll take some questions which we have. So you have again a clinical vignette. So 45-year-old women with type 2 diabetes and significant insulin resistance is treated with high doses of insulin therapy, 280 units a day. She develops skin thickening, hyperpigmentation of skin on the nape, axilla, basically acanthosis. Skin biopsy shows papillomatosis, hyperkeratosis, and acanthosis. Which cellular signaling dysfunction is most likely contributing? I think this is a very easy question, but I think again, you need to understand. So is it JAK-STAT pathway? Is it a MAP kinase PI3K pathway? Impaired PI3K MAP kinase pathway is downstream uniform downregulation of insulin-mediated signaling pathway and specific inhibition of mTOR pathway. Okay, think about it. We already discussed a little bit about this here, and I told you the problem which is there, right? Okay, so we have a question from the audience, and we have Das Munshi ask, how does insulin actually reduce glucotoxicity in a mechanistic explanation? Yes. So what insulin does is, remember, insulin reduces glucose, right? Rapidly. So it rapidly reduces glucose. Glucotoxicity is contributed by glucose. Lipotoxicity is contributed by fatty acids, free fatty acids. So when you give insulin, you actually reduce the glucose, rapidly reduce the glucose. By rapidly reducing the glucose, the oxidative stress on the beta cell reduces, and hence you have more insulin being produced by the beta cell, which then allows the increased production of insulin, which is supposed to happen because you have insulin resistance, right? So that is what happens. So it's like this, that you have insulin resistance, the body is trying to compensate, but on the other hand, the glucose starts rising, which prevents the increase of insulin production. You understand? Now, the increased insulin production actually is supposed to, reduce the glucose, right? Prevent the hyperglycemia. But if glucose itself prevents it from happening, then it leads to more glucose, right? So that's it. So how does sulfonylurea reduce glucose? The same way, right? So what you're doing is you're reducing glucose, right? Sulfonylurea again pushes the beta cell to produce more insulin, right? So it tries to overcome this barrier of glucotoxicity and hence reduces the glucose level, right? So that's the answer. Okay. Yeah. So yes, so we'll allow the poll question to run a bit while we take the last part of today's lecture. And let's see. Final part, and we'll discuss some miscellaneous points here about the insulin resistance and the other pathways, right? Okay. So there are 3 or 4 essential other aspects that we need to understand with insulin resistance. Now, this I already told you. One channel is closed, the other is open. Okay. So in a normal situation, you have the IRS, PIK3, AKT pathway, which is the pathway which is dealing with metabolism. And then you have the RAS, MAP kinase, mTOR pathway, which is dealing with, which is a mitogenic arm, which is dealing with growth of the cell and the cell survival and other things. When you have insulin resistance, the metabolic arm is lost. Mitogenic arm is still there. So theoretically, insulin resistance can lead to cancer. It should be, right? I mean, there is some proof to that. Okay. So that is one. Okay. So this is an essential, again, one essential lesson which is there. Another very interesting lesson. This is again important from, again, what we learned about acanthosis also. There is something called specificity spillover. Okay. Now, this is a very important concept in endocrinology. Okay. In endocrinology, a hormone is supposed to bind with its specific receptor. Specific hormone, specific receptor, like a lock and key. But when you have one hormone in excess, in a lot big number, it can sometimes bind with other receptor where it is not supposed to bind. Generally, these are receptors which are similar in structure to the original receptor, right? So that is specificity spillover. Now, insulin is supposed to bind with insulin receptor. But when you have insulin resistance, you have more insulin being produced, you have hyperinsulinemia. And this hyperinsulinemia, ultimately, the high amount of insulin starts binding with the insulin-like receptor, the IGF-1 receptor, right, which is supposed to bind with IGF-1. Remember, IGF-1 is the one which is dealing with growth. So when you have excess amount of insulin, it starts getting bound with IGF-1 receptor. And this binding ultimately activates the IGF-1 pathway also. And that is the reason why, I remember the AIMS professor, Dr. Amini, say this quite a few times in her talks. A newly diagnosed type 2 diabetic patient or a hyperinsulinemic pre-diabetic patient often appears pseudoacromegaloid, So it looks like an acromegaly, right? Your typical acromegaly features, again, especially if it's been for a long time, right? So this is called specificity spillover. It also occurs in many other conditions. For example, you have heard about gestational thyrotoxicosis. What is gestational thyrotoxicosis? You have HCG hormone, which is very similar to TSH in its action and its structure. And because of that, you have excess of HCG in pregnancy binding with the TSH receptor, leading to more T3, T4 production, right, which is called gestational thyrotoxicosis. So this is another condition where you find this, right, mechanism. Again, think about other ways where you find other situations where you find this kind of specificity spillover, which is again a very interesting phenomena in endocrinology, right? So again, this is a very interesting idea. Then I told you about this vicious cycle. Already told you insulin resistance leads to lipotoxicity, and lipotoxicity leads to insulin resistance. So it's a vicious cycle which is going on, which needs to be corrected. And this I told you, the free fatty acid, right? So the free fatty acid goes to the liver, leads to more, liver being accumulated with fatty acid, right? Okay. So, yeah. And this also we discussed that lipotoxicity leads to insulin resistance at the muscle. So this is a vicious cycle, right? So insulin resistance leads to more insulin resistance at different organs, right? And that ultimately leads to this cycle being perpetuated. Okay. Then, of course, the older theory was called the Randall cycle. And when Randall talked about, he said that, when you have two different fuels available, then body chooses one over the other. It's like a hybrid car. So body is like a hybrid car, okay, where you work on both electric power as well as the internal combustion engine. So you have glucose as well as fatty acid, which both of which are potential fuel. Now, when you have fatty acid available as fuel, the body prefers to use fatty acid as fuel, right? And suppresses glucose being used as fuel. Find that interesting thing, right? So when you have both, so it ultimately, this is what is Randall cycle, right? So the shift in the fuel, use, when you have free fatty acid available, that is being used as a fuel. In fact, initially, one of the earlier thinking of why insulin resistance happens before we understood lipotoxicity was probably because they understood Randall cycle, and they said that this is what happens. Fortunately, in humans, this phenomena is not that common. It is common in the animals, where physiological animals where you study this. Humans also it happens, but it's not the predominant action why you have insulin resistance. But basically, when you have free fatty acid available, the glucose is sidelined and free fatty acid is used as the preferred fuel, right? So this is what there is a shift in the fuel, and this is what Randall originally came with this concept, right? So the last lecture was, again, like I said, just a little bit of recap of what we think. We are exactly at 1 hour, right? Plan a 1 hour lecture, and we'll take some questions from you now. Just to kind of summarize, right? We have, like we said, there is in this selective disruption pathway, specificity spillover, we discussed this. There's a vicious cycle of lipotoxicity, and there's fuel utilization change with Randall cycle. Of course, Randall cycle is not that important for humans, okay? Which is now known. Of course, it was thought originally to be an important problem. Okay, let's then take the poll question back. We'll allow some of you to unmute and ask questions in a minute. So I think all of you got this answer correct, right? So you have the PIK3 AKD pathway, which is there. So I think 63% got it right. And let's take the last poll question, which we have today, which is, one second to run it. Probably need to, yeah. Okay. So you have 48-year-old male patient with type 2 diabetes, hypertension, dyslipidemia, has exertional chest pain. Cardiac cath reveals moderate triple vessel disease. His medications include ACE, metformin, statin, ACE inhibitor, and lab results show, HbA1c of 7.8, you have to multiply by 18. HbA1c of 7.2, fasting glucose which is high, HSCRP which is high. And what explains the pathophysiological process? Explains the link between metabolic disorder and atherosclerosis. Okay. Okay. Interesting question. I think, again, it's a bit on the tougher end of it, like I said. Okay. Let's take some of your questions. So I think we answered Dasmunshi, yes. We also answered yes. Then we have Khalid, who has asked, how can we differentiate that insulin resistance to either glucose? Oh, very interesting question, Khalid. I think it's a brilliant question. I think, it's a great question. Yes. To answer that, what I'll say is, how will you differentiate? Well, again, we'll discuss when we discuss the clinical aspects. A lipotoxic patient is typically has very high free fatty acid in the circulation, which if you could measure, you could. But one of the markers is to do a non-fasting lipid profile and find very high triglyceride. And if you find this pattern, this is a patient who is lipotoxic, right? A typical triad, I'll tell you, high triglyceride, low HDL, right? High VLDLs in your lipid profiles. You do non-fasting because you want to see the extreme of it. A lot of these patients will already have MSLD-like features. So they have SGPT, SGOT, especially SGPT, which is elevated. You'll find ultrasound, you'll find fatty liver. The HbA1c may not be that high. So that's, again, a lipotoxic patient. But even diabetic patients, full-flown diabetic will have lipotoxicity also. So that also can happen. But let's say, non-diabetic patient also will have this picture. So when you see this picture, there's a lipotoxic patient. What about a glucotoxic patient? Typically, very high glucose values, 200, 300, 400, right? So that's a glucotoxic patient, very high glucose. And at the same time, if you, let's say, could do their C-peptide, that will be low. So you should not, ideally, but if you do that, you'll find that low. So basically what is happening, and then you correct the glucose, and after a few weeks, when patient develops euglycemia, you check the C-peptide goes up. That's very typically the sign of glucotoxicity, right? So basically what is happening is a transient beta cell dysfunction, which is happening, which gets corrected when the glucotoxicity is corrected, right? And again, these patients are also insulin resistant. And they have actual clinical, Hitesh asked about exogenous insulin resistance. They have exogenous insulin resistance. Basically, when you give them insulin, initially, for a long time, you'll actually have to give them IV insulin, and you have to, actually give much higher doses for it to come down. And once the blood sugar starts coming down, that's when the same dose of insulin becomes more effective. But great question, Khalid. Thank you for that. Okay. We have an anonymous attendee ask, should we start pharmacotherapy? We'll discuss the treatment aspect. We have a long time to go. We'll discuss in the third lecture. Okay. So management will discuss in detail. Sir, is there a drug for targeting lipotoxicity? Yes. So all the drugs which act on the insulin resistance pathway, including your lobiclitazone, pioglitazone, your saroglitazar, your even fibrates to some extent, metformins, GLPs, SGLT2s will all work on lipotoxicity. And of course, lifestyle measures. Okay. Nisha has asked, any particular cancer that can be linked to insulin? Well, there has been suspicion. I think nothing confirmed, and very difficult to really prove that also. So yeah, Dharmadev will allow you to ask. Just let me finish the questions which you put in the question, right? So again, Hardik has asked, what is the effect of insulin resistance on thyroid hormone and TSH receptor? Well, not much. It's the other way around. So hypothyroid people tend to be insulin resistant, right? Again, because of the lipotoxicity aspect. So it's not the other way. Okay. So again, Hardik has asked, also, does primary yes, so it does. So hypothyroidism does lead to insulin resistance, right? It does. Because remember, hypothyroidism is a state of, again, lipotoxicity, right? So again, that's the thing. Again, ability to, accumulate fat versus not accumulate fat, disperse the fat. That's the idea. Okay. Masoom has asked, Mohammed Masoom has asked, can early initiation of insulin therapy in newly diagnosed type 2 diabetes provide? Yes, it does. Yes, it does. In fact, this has been well proven. This is called short-term intensive insulin therapy, which was originated from a lot of Chinese studies. So yes, so newly diagnosed patient, when you give them insulin, they become, the glucose comes down and they actually develop diabetes remission, right? So that's it. It's true. It's true. Good question. Khalid, can statin improve insulin resistance? No, it doesn't. Okay. So statin is a different because it does reduce chronic inflammation. So maybe on a long-term maybe it does in a sense on a long-term basis, but an acute short-term, no. Right? No. Okay. Sir, autoimmune hypothyroidism related with insulin? Yes, I think that we answered. All forms of hypothyroidism or primary hypothyroidism will be linked with has insulin resistance. Dharmadev has asked, high TG, low HDL, C-peptide high, HbA1c is normal. Fibroscan, grade 3 fatty liver. Yes, candidate for saroglitazar also. Yes, can be given. Sumit has asked, is increased visceral fat and lipotoxicity same? Yes. So no, well, it's not the same, but it's, the consequences. So again, visceral adiposity is linked with, lipotoxicity. How do you measure it? You need to do either you can do a, CT scan, or you can do so you do an axial CT scan, look at the visceral fat. You can actually see the visceral fat in the CT, or an MRI also you can do. And other way of doing it is a DEXA scan, right? So again, DEXA scan, some of the DEXA machines also will give you the estimation of the visceral adiposity also. Okay. Very low carb diet will improve glucotoxicity. Yes, it will. It will improve glucotoxicity. It will improve lipotoxicity also, both. So low carbs will improve both gluco and lipotoxicity. Yes. Again, Dharmadev has asked, sir, metformin use as anti-cancerous. We'll discuss the treatment aspect later. Yes, but it does have anti-cancer effect, and probably because of these mechanisms. Lipotoxicity in insulin secretion, does it impact? No, it doesn't impact insulin secretion. It's mainly insulin resistance. Glucotoxicity impacts insulin secretion. Okay, Nirav has asked, newly diagnosed patient with type 2 diabetes with severe insulin resistance. I love this interaction, so please continue this for all 4 lectures of ours. Newly diagnosed patient with type 2 diabetes with severe insulin resistance who would have beta cell dysfunction already starting ICU. It's a debatable thing. Initially, it will reduce the glucotoxicity and improve the beta cell function on a long-term basis. Some people claim that it can lead to beta cell dysfunction. I used to believe that, but the modern SUs don't do that. So glimepiride and gliclazide don't do that. So older generation, yes. Right. I hope that answers the question. Nikhil has asked, can isolated hypertriglyceridemia be a marker of? Yes, it is. So hypertriglyceridemia is a marker of lipotoxicity. It's a good marker of lipotoxicity. In fact, next time we'll discuss triglyceride glucose index, which is a very good marker of insulin resistance. Dharmadev has asked lobiclitazone. We'll discuss treatment first, right? Treatment, please leave your treatment questions for part 3. Just out of curiosity, when is endogenous hyperinsulinemia and it's not able to act, how does exogenous insulin? Yeah, so because of the reduction of lipotoxicity, how does, glucotoxicity. So exogenous insulin and SUs, we give to a patient who is glucotoxic to reduce glucotoxicity. By reducing glucose toxicity, by reducing glucose level, you improve the beta cell function as well as you improve the insulin resistance. That is how it works, right? Okay. Tanjot Kaur has asked, sir, your talks are very informative. Thank you so much. Thank you. Thank you. Thank you. Thank you. And does statin have pleiotropic? We don't know. I mean, we're not very clear whether it has impact, good or bad. Difficult to say. We don't know that, right? Okay. Neelam has asked insulin resistance in LADA patients. Yes. So LADA patients can also, even type 1 patients can have insulin resistance. In fact, initially, so you would have seen a lot of type 1 patients coming for the first time. They often have infection or something like that, right? And that is first time they get precipitated, in fact, going to decay. So there is a component of insulin resistance there also. Okay. And we'll take this last question. Dharmadev, brittle diabetes, can we talk on? That's a different topic altogether. Khalid has asked, what do you think of patient using insulin? We'll discuss treatment, like I said, later. Okay. So I think we are done today. We're already ahead short of time. If anybody wants to ask a question live and unmute yourself, can ask. But don't ask about treatment right now. So we'll discuss treatment later. Dharmadev has been, wanting to ask something. So yes, Dharmadev, you're live, so you can ask a question.
Sir, it is regarding our one of the patient which came to you. She came to you.
Okay, came to me. Okay. Yeah.
Okay. The name of the patient was Nehal, an elderly,
Okay.
25-year-old female.
Okay.
She came with DK and she was then for diagnosed with type 1 diabetes. We did her C-peptide, GAT65 antibodies and everything. And you did, sir, postprandial C-peptide, I think.
Yeah,
So 2
yeah,
hours
yeah,
fasting, which you do.
Yes,
If
yes.
the random blood sugar is less than 200, you go for it. I've heard about this in one of your lecture. So just you can, sir, highlight 5 minutes on that, where to do, in which patients to do. Because what I do is I do a fasting C-peptide in my practice more. So what are the indications and in which subset of patients we should ideally go for it?
Yeah.
And second question, sir, when to repeat a C-peptide level?
Okay.
Because we see some of the patients with 0.3 to 0.7 C-peptide, which you also, regarding this, you also mentioned in one of your lecture. It's, I've been following you on YouTube also. And Dr. Abhichandran is a student. So he is also a fan of you and he is also talking about you many a times. I've met him, and so I'm also following you on YouTube also. So, sir, you can just give a crack on or give a small conclusion, practical approach of C-peptide in 5 or 10 minutes, sir.
Okay. Okay. Thank you, Dharmadev. First of all, thank you so much. Thank you for attending the lectures and listening to the lectures on YouTube. We actually have I probably have a lecture on C-peptide itself on YouTube, so you can probably check that out. So I think that will give you more detail, I think. But to answer your question, see, one principle, I'll just tell you a principle, which will be, kind of a rubric for you to think, and then you can apply that to C-peptide also. Okay. Now, one essential principle in endocrinology is that when you have any hormone which you think is deficient, try to stimulate it. And when you have any hormone which is excess, try to suppress it. Okay, simple. So let's say a patient comes and I'm suspecting the patient has C-peptide deficiency, which is essentially insulin deficiency. What I'm seeing is I want to stimulate it. Let's see how far I can push it, so that I get the actual value, right? For example, another example I tell you is adrenal insufficiency. So when I'm thinking of cortisol deficiency, I try to stimulate the adrenals to produce more cortisol. And if it is not able to produce more cortisol, that means it's deficient. Okay. So what I'm doing is, why would I not do a fasting C-peptide, and why would I do a post-meal C-peptide, or why I'll do a stimulated C-peptide, is because I want to push the C-peptide to the limit. So if the patient has, a heavy meal, patient's glucose is high, you're trying to push the C-peptide, ideally should be able to match, but it doesn't match. That means the body is not able to produce insulin to the level it should, and hence is relatively insulin or completely insulin deficient, leading to me confirming that the patient has insulin deficiency. Now, you asked a very important question about one patient specifically, that why did you do a C-peptide even when the blood sugars were high? Well, what I do is, in such patients, so patient comes for the first time, my idea then is that if in her case, if the blood sugar, she's already glucotoxic, and if I do a C-peptide, and if the C-peptide comes to normal, more than 1 or 2, 3, 4, then this more or less is certain in my mind that this patient is not completely insulin deficient. Get my point? So I do one test straight off the bat. If I get that value to be normal, then that somewhere stays in my notes or in my mind saying that this patient is not completely insulin deficient. And because of that, what I'm going to do is, in future, probably consider retesting or probably looking at, a mixed meal stimulation test, which is a more gold standard. So the point being, Dharmadev, is that remember this point, right? Whenever you have a hormone in deficiency, try to stimulate it. Whenever you have a hormone in excess, try to suppress it, right? So if I am trying to diagnose insulin deficiency, then I am trying to stimulate my C-peptide to see how far I can push it. And if it pushes to a great limit, the patient is fine. If you can't push it, that means there is deficiency. And that is what ultimately the point is, right? So, and we can have a detail, maybe, if Juventus is gracious enough to sponsor a lecture on C-peptide, we'll have a 4-part series and allowed to talk on C-peptide for 4 hours, right? But, like I said, it's a different topic, but thank you for that. We'll take one more question and then we'll end this. Khalid, please go ahead. Khalid, if you're there, like to speak? Yes.
Hello, sir. Are you hearing me?
Yes, I can hear you, Khalid. Please go ahead.
Yeah, thank you for your elegant lecture. And my question is really composed of 3 parts, because I am seeing in the practice that we have patients having, like what you say, classical picture of insulin resistance, like they are having acanthosis and they are obese and they are having disturbed lipids. And in this patient, we give all the weapons of treatment. Like in this patient, we give them combinations of sulfonylurea, GLP-1, insulin, basal insulin, bioglitazone, and metformin. And despite of that, they are not responding. And all the A1Cs are above 13. And is there any?
Yes. Again, Khalid, I'll give you a quick answer, which is going to, change your practice. You know what you should do for this patient? Admit them, give them an IV insulin, right? What happens is, now this patient, what you said, right? HbA1c of 13, nothing works. right? This patient is both glucotoxic as well as lipotoxic. Lipotoxicity will take time. Glucotoxicity you will be able to reduce, but the only effective way you will be able to do it rapidly, which you should be doing, is if you give this patient IV insulin. So what you need to do is admit the patient for a day, even if you keep it in the daycare, that's fine. Keep her for a day in the daycare, start her on IV insulin, bring the blood sugar down through IV insulin to a level of about close to, let's say, 200 or less. Now, if you're able to bring the random sugars there, keep it steady, wait for maybe few hours, and then start introducing your medications. You'll find that your medications will be more effective, right? So this, now you will say, what will happen if the patient goes home? Well, this effect, once you brought the glucotoxicity down, the effect stays for a few days. So you'll have a patient having good, smooth control for a days. After that, then your other medications will start taking over in terms of reduction of lipotoxicity. So that is what you should be doing. Then there'll be certain patients who will not respond to IV insulin also, and they are having some sort of other disease which we're going to discuss in the next part. So we'll please attend that. But there will be certain other insulin resistance related disorders which will not respond, which are very rare and very difficult to treat, right? But a routine garden variety patient, probably hopefully that's the kind of patient you are dealing with. Admit her, give her IV insulin, and things will become better. That is what I'll suggest. Yeah. Okay.
Okay,
So,
thank you very much.
yeah. So I think we are short of time. There are other people who want to ask questions. Please keep the enthusiasm on. We'll have the questions next time as well. We have 4 parts, so we're meeting for the whole month. So yeah, Abhishek.
Yes, sir. Yes, sir. And so, matlab, it was really a fascinating kind of session. Very interesting. Okay, very informative. And the best part was it was very interactive as well, sir.
Yes.
And so I consider it as a proud privilege to offer the vote of thanks. And on behalf of the entire Zuventus team, sir, I express my heartfelt thanks, okay, for conducting the session so well, sir. And in fact, I shall be failing in my duties if I do not thank our esteemed participants who have joined virtually from all over the country, without whom this event would have not been possible. And this being the first of the webinar series supported by Zuventus, makers of Lobetron. Next week, again, we'll be meeting to know more on insulin resistance. Till then, thank you once again and promise to be back soon with another interesting webinar on insulin resistance and hope to have all of you with us again. Thank you, everyone. Thank you, sir, once again. Thank you, sir. Good night.
Thank you, Abhishek. And to all the viewers, once again, thank you so much for joining. Again, if you have friends who are interested in this, please send a word out. They can also join next time. Again, very graciously supported by Zuventus, Pharma, who have made this possible. Like I said, complete editorial freedom. I think, this is a great thing. It's a great learning opportunity. So if they have missed the first lecture, they can attend the lectures. They can see the lecture again, and they can join us for the next lecture, which is going to be even more interesting, right? So I promise you that. Thank you. And thank you, Abhishek, once again for the making this happen. And to all of you, have a pleasant night. Good night, and hope to see you next week. Same Wednesday, 8:30, where we'll be discussing about the clinical and biochemical aspects of insulin resistance, where we'll now dwell into the clinical aspects, acanthosis and the clamps and quickies and all those things, right? So we'll discuss that next time. So keep your questions for that next time. Thank you. Good night.
Thank you, sir. Good night. Bye.